Welcome to the Birth Lounge Podcast, an empowering space for expecting and new parents to hear candid conversations with experts, support your mental health, and learn the tips and tricks that thousands of parents have used to craft their ideal birth. We will answer all of your questions, the scary ones and the weird ones, to help calm your fears and feel confident going into your birth. I'm going to help you redefine what birth and motherhood looks like and how to embrace your journey. I've intentionally crafted a list of experts to help you navigate pregnancy, explore your birth options, and plan for postpartum so that it can be a time of soaking in your tiny human. We're going to go there on all the hard topics so that you can dive deep into finding your confidence and freeing yourself from fears around birth. With over 10 years of experience in family education and a master's degree in human development and family studies, I created this podcast as a way to share the resources parents need to make educated and informed decisions about their care in pregnancy and childbirth. This is a birth community driven by evidence-based information and research in hopes to help you explore your options, understand your rights, and know what choices you have along the way when it comes to birth and beyond. I'm your host, HeHe. Now let's get to the good stuff. Nathan, welcome to the show.
Hello, HeHe.
Welcome back, I guess I really should say, because you've been on previous episodes. But today we're talking about something very rare. You were just saying that they actually don't happen that often, but I had reached out to you because I feel like, and it could be because this is a topic that I don't know very much about. And so it is very in my face when people ask about it. And I don't have an answer to give these people, but I feel like pretty often I have people reach out and say, hey, I've been diagnosed with Velamentous Cord Insertion and I'm looking for some answers. So today I'm very excited to dive into the different variations of how our umbilical cord can attach to our placenta and how each of those variations might impact labor, what you might hear from your care provider, what does the data say, what are the risks, things like that. So before we dive in, can you explain to us what VCI is and MCI is?
So these are two of the innumerable acronyms in the world of birth. An MCI is a marginal cord insertion, which is basically, it's not in the center of that big disc, the big life vest, so to speak, of the growing baby, the placenta. It's maybe more than 2 centimeters off center. So it's acentric. And that will be relevant in our conversation. But ideally, you have a big old disc with all these beautiful cotyledons, this beautiful placenta, and the cord is in the dead center. Similarly, if you hang up a picture on the wall, you don't just put the picture kind of on the wall. You want it dead center, right? It looks good there. Usually you want it on a stud, so it's central, whatever, right? So if we can just imagine that if the cord is not inserting in the dead center, then we have this myriad of other things, and it's on a spectrum. So marginal cord insertion is usually diagnosable by ultrasound, but you have to really be looking for it. And normally it's diagnosed after the fact. So that's actually also relevant to our conversation because most of the data that we have is going to be derived from the birth has happened. We've looked at the placenta. Holy crap, look at that. There's a velamentous cord or there's a marginal cord. So what is the velamentous cord? This is when the baby's umbilical cord inserts into a part of the membranes, this combination of chorion and amnion. It inserts out beyond the boundary of the placenta itself, courses through these membranes, and then enters the baby's life vest. So it's hard to use my hanging a picture analogy for that, but it would be kind of like hanging a picture from a string that's then attached to the stud, right?
Yeah.
So these are two scenarios that sometimes arise, and there's nobody out there that's a true expert in this because we don't have a really good way of diagnosing it before the fact. When you see it, you know it. But just because you don't see it doesn't mean it's not there. So that's probably why I think everybody is a little bit confused, including myself and every single doctor out there. We just sometimes don't know.
Yeah. Okay. So you said marginal cord insertion is usually diagnosed after the fact. Same thing for velamentous. Like we usually don't know prenatally.
It's interesting. So we'll talk about some of the risk factors here and what I mean by that is some of the risks that these conditions may pose. But one of the important associations specifically with marginal cord insertion is probably a pretty good association with what we call Vasa Previa, which I know you had
Mm.
also brought up in your sort of pre-interview questions. So there does seem to be an association between what's called Vasa Previa, which is when you have generally have a Velamentous cord insertion, but those vessels happen to be running right across as they're coursing towards the placenta. They happen to be running right across the cervix. So there is an association between those two, meaning that if you see, hey, there seems to be some sort of placental blood flow around the cervix, let's look a little bit more carefully. And then we go in with our really high-tech, sophisticated ultrasound. And then we can say, oh, you know what? Not only are the vessels running over the cervix, it also seems like this is a Velamentous cord insertion. So now we have to look at this as a dual thing. We have possibly an abnormal cord insertion into the placenta, which in and of itself may have risks. And of course, now we are at this point in time, as we're looking, there are fetal vessels that need to be transected by a baby coming through in order for the baby to come out vaginally. So
Yeah.
you can see how this is why we have our high risk doctors, Dr. K, and a lot of these specialists, and Dr. Chavira, because they were trained to look very carefully with an ultrasound. But if you're not looking specifically for these things, sometimes they're missed. And so most of our data is from looking at placentas afterwards and being like, by golly,
Hmm.
this was a Velamentous cord insertion, or look at that. That cord's not even close to the center. It's like right on the edge of the placenta, right? And of course, this is a spectrum. So I think that should give people a good idea as to why sometimes it's a surprise and oftentimes we just don't know beforehand. And that
Yeah.
actually should be a little bit reassuring because there's a lot of babies that are born with these conditions and we never even knew in the first place.
Yes, that's what I was gonna say. I actually found a lot of comfort in that because if it didn't pose a problem in labor, I guess it was non-problematic. Of course, the risk exists, and we want people to know about those, but for most cases, it's kind of non-problematic. What would cause this? What would cause your umbilical cord to kind of insert in variations?
So we have to go back to the embryology piece. Like, where did this tissue even come from? So when the embryo started forming, there's these various cells that can go anywhere in this brand new little embryo that's a pea, the size of smaller than a pea. It's a pinhead. And the cells are dividing. And then some of those cells actually will implant and invade into the wall of the uterus. Those are the trophoblasts. The cytotrophoblasts start kind of like cancerous, kind of like a cancer growing
Hmm.
into the wall of the uterus. And we get this thing that emerges called a placenta. And confluent with the placenta is the chorion. And then on the fetal side, there's a layer called the amnion. And those two comprise the membranes. So when we ask, if we're posed with any question about an abnormal anything related to the cord or the placenta or whatever, my first thought is there some degree of variation as to how blood is flowing to and from these uterine tissues that may lead to an abnormal placentation, meaning abnormal location of the uterus? Is it over the cervix? Is it growing into the wall of the previous hysterotomy site? All of those things are really a consequence, including MCI and VCI, most
Hmm.
likely of some degree of disruption or variation in what we would call normal as to where blood is able to flow to the uterus at large.
Hmm. That's so interesting. I get really deep in thought when I think about the human body and all the processes that it goes through, especially in pregnancy, obviously. But the whole idea of it could originate from that very first zygote, is that right? A fertilized egg?
That's the zygote. That's the moment that they meet. And then as they
Yeah.
start all dividing, then all this magical stuff happens. We could go into that in a completely for 6 hours in a different
Yeah. We need a
conversation.
new podcast for that.
Yeah, yeah,
Okay, so
yeah.
we keep kind of hinting around at the risk. Seems like most cases it's kind of non-problematic, but let's say we do find one. Now, what kind of conversations are we having with our provider about associated risk with it?
So here's one of the limitations of just being an investigator that looks on PubMed. There's a whole bunch of data out there that is behind paywalls. You really can't see what the methodologies were and whatnot. But what I will say, after finding countless other studies that weren't behind paywalls that had enrolled 10, 20,000 women, things singleton and twin pregnancies, like this one study, 623,000 singleton pregnancies
Wow.
were looked at. So that's a pretty darn big data set.
Yeah.
And I think this one was from Norway, but and they generally just do a good job
Not
of
surprising.
yeah.
Yep.
Yeah. One of, I think, the important considerations here is if you are a pregnant person who has absolutely no other risk factors for something bad happening, there's a good chance that this is not going to be the thing that causes any major issues. However, a lot of the data that actually supports this notion that MCI, VCI, let's focus on MCI because VCI, because of its association with Vasa Previa, and a variety of other things, it actually is much higher risk than MCI. And MCI
Okay.
does happen to be a little bit more common. In fact, if you guys want to know, I actually pulled those numbers. So the risk of MCI, marginal cord, in singleton pregnancies, meaning there's one baby growing in there, is around 5 to 6%. In twin pregnancies, maybe doubles, maybe about 10 to 15%. The VCI is around, consistently, it's 0.9 to 2% in the singleton pregnancies and maybe 6% of twin pregnancies. So bearing that in mind, we just brought up another risk factor. We have a twin pregnancy and we have a singleton pregnancy. So the outcomes for MCI and VCI should be different, and they are.
Yeah.
We also have an association between these conditions and a short cord. We also then have some data that a short cord is associated with breech. Not every time, but it's an association. It doesn't mean it's a causation. So when we consider the myriad of other things that can be happening in a pregnancy, we have to look at the data a little bit more discerning, and we can then say, okay, if a woman has a bad outcome in childbirth, is it because, and when I say bad outcome, something as simple as a low APGAR score or
Sure.
NICU admission or something like that, we have to take the whole picture into play. It's very hard to identify MCI or VCI as a single contributing primary risk factor for something bad happening from what I'm looking at in the data. But if you then, and a lot of the authors say, here's the limitation. Like, we don't know if this is because of the MCI or were they actually kind of borderline diabetic and that's why maybe the baby didn't grow well, or maybe they weren't very well nourished. Where was this study done? Did they have access to whole foods? Were they getting enough sleep? Everything can contribute to a small baby. But so they admit that we had a hard time controlling for a lot of these variables. But these larger, robust studies do show that there's probably an increased risk of things like low APGARs, NICU admission, especially for the Velamentous, for the MCI. So I have some of those numbers if you'd like.
Yeah. Totally. We're all nerds here, so give us all the numbers.
So when we're considering if one of these diagnosed things, whether it's MCI, diabetes, whatever, is going to be a risk factor, we have to compare that to the absence of that. And when we do that, we create a ratio called an odds ratio. So the odds of a baby having a 5-minute APGAR score of less than 7, right? That's the second score we give, which is usually a reflection of what the resuscitation efforts were able to perform, not the 1-minute APGAR, which is really how was the baby doing inside, which already to me is a little bit problematic. But anyways, the risk is almost double with a Velamentous cord. The 5-minute APGAR is going to be less than 7. So it's 1.87. With a marginal cord, it's a wash. Already, the more common of these two conditions does not show that the baby's more likely to have a low 5-minute APGAR. When we look at likelihood of being transferred to the NICU, we're talking about the baby here, of course. It's a 1.8 to 1 ratio. So you have almost a double the risk with a Velamentous cord of requiring NICU transfer. With the marginal cord, it's 1.29 over 1. So there's a slight increased risk. Perinatal death is twice as high for Velamentous cord. Of course, that absolute risk could be 0.1% doubles to 0.2%.
Totally.
We have to consider absolute risks here. With marginal cord, it was again a wash. Low birth weight was 1.8 for Velamentous and 1.3 for marginal. So if you can start to get the picture here, the marginal cord does not seem to have worse outcomes for baby. Velamentous cord, in some cases, yes, depending on what outcome you're looking at. But of course, we don't really know why these conditions arise in the first place. Is it a folate deficiency? Were you taking too much folic acid versus folate? Who knows? Nobody's asked the question yet. Was this person taking some supplement that we just don't know has some sort of issue with how babies are born? Did this person have something like a uterine artery embolization? I haven't found a study that looked at that, which is sometimes used for uncontrolled bleeding postpartum, where we go into the IR lab, we take you down from your C-section room. We haven't even closed your belly up necessarily. We plug the uterine vessels with a foam material that blocks the blood flow to the uterus, stops your bleeding. but may have some consequences down the road around uterine blood flow, which
Wow.
is maybe associated with abnormal placentation and MCI and DCI. So all of this is to say that if we were to try to isolate MCI and DCI as risk factors for baby, MCI seems to not have any major issue in a 600,000 woman study. VCI definitely, but we're talking about relative risk, not a massive increase in absolute risk.
Sure. Are we going to see these babies respond to labor differently? Are they going to be able to tolerate labor? Does it actually impact the flow from the placenta to the baby?
That's a really good question. So in one of these studies, they looked at 738,000 women, and these were
Okay.
all single pregnancies. The women were of average reproductive age. Many of them had multiple babies. The risk of cesarean for the Velamentous cord insertion in this group was 22%, which is actually pretty average. The
Wow.
risk of C-section for marginal cord was 18%, which looking at the United States, if we had an 18% C-section rate, that would be awesome, but we don't. We have a 37 plus C-section rate. So I don't have data specifically from the literature that supports this notion that either of these conditions necessitates C-section or suggests that the babies are going to have a terrible time in labor. But let me add to that, because what a lot of people, including some really big name organizations, like to do is they like to see evidence solely as what you can find in the literature. And if you're looking at literature as the only means of determining what the risks are and how you counsel, which of course that practice is something done by non-clinicians. You can go into PubMed all day and write books and all this stuff, but if you don't sit with birth, then your
Mm-hmm.
opinion is limited, because evidence-based medicine is more than just the peer-reviewed literature, which is fraught with issues in publication, the publication industry as a whole. The other
Amen.
the other legs of evidence-based medicine comes from people who sit with birth like you. If you haven't ever seen it and you've attended 200 births,
You don't really know birth
yeah,
issues.
exactly. Right. And one of our friends, Stu Fishbein, if you were to attend a birth with him or Christine Laria, who you're going to be meeting both of them at our upcoming conference in August,
Yeah.
um, Christine's attended probably more vaginal breech births than any practicing US-based clinician. And she's not even really US-based. She got all that experience in other countries. She's global midwife. If you were to go and attend a birth with them and your baby's butt down, you have a much greater chance of that clinician being able to help you through that versus the typical OBGYN or
Mm-hmm.
midwife who doesn't do that type of training. So the clinician experience is a part of this as well. And then the last thing is, what is this person's story? What are their values? What are their preferences? That's the third leg to evidence-based medicine. Having said all of that, the reason I'm saying all that is that I have seen multiple marginal cord insertions. And what we would do, even in residency, especially in residency, because we were at a very high-risk referral center at Kaiser in LA, it's a great place to train because I got to see everything. It wasn't a small community hospital with a bunch of like stragglers that didn't have anywhere else to go. This is where everybody came if they had some issue as well. So we saw a lot of marginal cord and IUGR, which is
Mm.
intrauterine restriction. Sometimes these babies were smaller, but again, was it this that caused it, or was it that combined with all these other things that caused the small baby? And did that small baby necessarily have a hard time in labor? No, not necessarily. And how many times did I see a cord that was like, whoa, way off to the side here? And that baby just came out in 3 hours, right? Couple pushes and baby's
Hmm.
out. No fetal heart rate abnormalities, nothing. So in my experience, I don't see this alone and say, oh boy, that's a baby that can't go through childbirth. We can't induce. Maybe we're a little gentler with augmentation, but I would say that for any birth. And like
Same.
if we have to intervene, it better be a whiff of Pitocin as opposed
Yeah.
to cranking up to 20 over a couple hours. And then, of course, does this necessitate C-section? I will say the same thing I say to everything. You don't know until you try. And if there is a big concern about this baby's ability to tolerate labor, we have ways of determining that beforehand. And there is no doubt that some babies simply maybe aren't fit for childbirth and they're going to die in that process. That is a harsh reality for our medical
Mm-hmm.
system. You have no entitlement to have a baby come through safely any more than you have an entitlement to live beyond 150 years old, right?
Yeah.
So that's a harsh reality that we won't get into now. But with that in mind, when we are anticipating that a baby might be struggling a little bit, we have ways of monitoring. We can do biophysical profiles. We can do NSTs. We can look at fluid. One interesting statistic I found was one of these two conditions is actually associated with polyhydramnios.
Wow.
And the other is here, I think I have it right here because I highlighted a whole bunch of stuff here. It's in one of these papers. When you see low fluid or high fluid, that should prompt further investigation. But if you've got a baby that's moving and rolling and kicking and growing right along the normal growth curve, and there's no reason to suspect that this baby is not getting adequate nutrients and adequate nourishment and oxygen, then there's no reason to believe, regardless, they might have two cords that are plugged into the wrong place. It doesn't matter to me. If the baby's telling me the baby's fine, then the baby's probably going to be okay in childbirth. So if there's a suspicion that maybe this baby's going to have a hard time, whether or not we have VCI or MCI or whatever, of course, the contraindication of Vasa Previa we can get into. But for me, I would love to just get more information before we start pushing people away from a vaginal birth towards C-section because of the possibility of that low risk thing happening. So we can do
Yeah.
contraction stress tests, we can do serial BPPs, we can do NSTs once a week. We can just see how is this baby doing in there. And if mom feels good and there's no other risk factors, we owe every single woman the opportunity to at least decide, hey, I'm going to try this out. And if you're worried, we have an operating room right here. And
Yeah.
hopefully you have a doctor that doesn't have a super low threshold because of some recent bad outcome, because most of these babies are probably going to be just fine.
Yeah, that's super comforting to hear. I mentioned at the beginning of this episode, I didn't really know a lot come into this conversation, but I think instinctually, I always guided these women to just ask more questions. Can I do this to monitor baby? Can I do this to monitor baby? Can we wait for spontaneous labor? Can we avoid Pitocin? Can we just see how my baby tolerates it? Some people would choose a C-section because their provider is suggesting that. And then some people do kind of have the confidence to push back on that. So it is really comforting to know that is a safe alternative is to monitor things and see how your baby tolerates it.
Yeah.
Another question is, would this knock you out of having a home birth? Would you not be eligible for a home birth with maybe either one of, and maybe it's different for NCI versus VCI because they are so different.
It kind of read my mind there a little bit. So we know that, at least from the data that I have available to me, we don't have a huge risk that you're going to fail in childbirth, right? The C-section rates are pretty comparable to what we're already seeing in the United States. But there's another paper here. I'll send you these so that people can look into this for themselves. These are all free access, open access on the internet on PubMed. I did find an interesting, this was the same study that looked at over 600,000 singletons. A body of the outcomes looked at what happened after the fact. So we're looking at things like hemorrhage and this and that. And this was actually pretty interesting to me. So for a Velamentous cord insertion, there's a greater chance of losing over 500 cc's of blood. Now, of course, it's hard
Wow.
to predict or to estimate blood loss, but if you have the ability to weigh chucks and all that, we have ways in the home of kind of estimating this. But in general, we saw a little bit more blood loss with a Velamentous cord insertion versus not having a Velamentous cord insertion. The marginal was effectively a wash, so no increased risk of postpartum hemorrhage over 500 cc's. But what about postpartum hemorrhage over 1,500 cc's? There's a double the risk with Velamentous cord insertion versus not having a VCI, meaning it's
Wow.
still unlikely, but there is a higher chance of a massive blood loss after the fact. Not so with marginal. Again, manual removal of the placenta. This gets into your first question, HeHe, which is, why does this happen in the first place? And we just don't know. But we do know that there's a 5.21 odds ratio with Velamentous cord insertion of requiring manual removal of the placenta versus not having a VCI. So that there is some important information for us to be talking to our clients about with regards to marginal had a slight increase risk, but not, for me, not very clinically significant, 1.16. Now, this one's also relevant. 3.29 was the odds ratio of requiring postpartum curettage, where we actually put you in stirrups and go
Yeah.
in with a sharp instrument to remove stuff. So that tells me that maybe there's an abnormal placental attachment that might be a part of the underlying pathophysiology that also led to the abnormal cord insertion. So it all comes back to your original question. If there's something up with how this placenta starts to grow early in pregnancy, probably specifically the first and second trimesters, it may set you up for a variety of other things. Like there's poor attachment, so we need to curettage. There's poor attachment, so we need to remove it. As a consequence of those things, there's much higher risk of this super high, over 1.5 liters of blood loss in the postpartum periods. Does that mean that you shouldn't try to have a home birth? No, it should mean, though, that we should be extra thoughtful about how we're preparing. How far are we to a nearby hospital? Those are all the types of things that I would be counseling. And if they were like, to hell with that, I'm not going to go, you can cut my head off before I go to the hospital. That's still your priority. Like you have the decision-making power there. Every midwife and doctor who attends births out of the hospital would just need to decide, okay, can we infuse blood in the home? It's unlikely. Can we get some uterotonics? Absolutely. My collaborative midwives ask me all the time to stock them up on Cytotec and Methergin, and God knows what. A lot of midwives are also able to start IVs. So knowing that there may be a higher risk that placenta is not going to come up by itself and that you're going to get a lot of blood loss if you try to remove it, we got to be prepared for that. And that needs to be a part of our counseling as well.
For sure. And choosing the professional that you choose, right? So choose someone that hopefully has experience with this and or is willing to do the work alongside you to make sure you're doing kind of the right prep. Is there anything in your brain that might prevent this? Is there something, is there a way that we can change our diet? Are we needing more organ meats? Are we needing more, obviously, overall in America? Yes, we need more organ meats. We need more whole foods, fruits and veggies. But is there anything that you can think of? I don't know, you brought up folic acid and folate, and I know that was just an example, but is there anything that you can think of that, I don't know, this just seems so crazy.
Yeah, if I had $1 billion, what I would do is enroll 10,000 women and get them on my sort of regimen, probably a
Mm-hmm.
regimen based on what you're counseling women on.
Mm-hmm.
Like we need to prioritize sleep. We need to get a lot of whole foods that have a ton of nourishment in it. And they're
Yep.
foods that a lot of doctors probably don't eat themselves. Like I have a can of smoked oysters 3 times a week. It's not fresh oysters, doc, so there's unlikely that there's going to be food poisoning, but there's so many nutrients in oysters and beef liver, but also other organ meats that you mentioned. Those two alone with like high quality sleep, getting the thyroid and the blood sugars under control, all of those things, it would be absurd to suggest that getting those things under control wouldn't lead to better outcomes in general.
Totally.
But we would need a lot of money to do that and to look at 10,000 pregnancies. We'd have to look at their first pregnancy and then do it again in their second pregnancy. Does it parity plan? It's just so hard to conduct a really good study.
Hmm.
So your question was just about
Just is
lifestyle
there
stuff?
anything that you think could help this? Or is there anything even precautionary? Stay away from this, or think about adding this to your diet or a supplement, or just literally anything.
Yeah, so in my community, people are having left and right just awesome births. And I don't think it's just my community or my approach. I think it's that people have actually started to assume some control over those things that they can control. And that actually, I think, not being afraid, not really succumbing to things that don't intuitively feel good to you, finding and investing in a really good prenatal. I think all of that is helpful. But truthfully, of all things, if you can like 3 to 4 months ahead of your pregnancy, start really focusing on sleep, these types of whole foods. I would add eggs and bone broth and a really nice cod liver oil or something, which
Mm,
actually has it over other fish oils. When you get those into your diet, we don't actually need data to support that getting clean air, clean water, clean food into your body, prioritizing sleep, getting like on the same page with your partner, like really connecting and nesting together, which I actually didn't do a great job of in our pregnancies. I wish I could take those back. Those all are going to help to regulate how the body heals. And if you were to look at just this pesky history of prior C-section, which by the way, I don't even consider a risk factor anymore.
mm,
I've just seen it not happen so many times that it's
yeah.
like, if it happens, that's a out of the blue thing. But I also really think that if we were to emphasize the importance of this postpartum period and lying in and allowing your body to just recover as long as it needs. Look at Lindsay Cantu. She's like beefcake, superwoman. And she wasn't working out afterwards. She was walking. She was
Hmm.
gradually getting back to movement. That's the types of leaders. That's the type of advocacy work that we need.
That's what we
And
want to see on Instagram and not people getting right back to it 2 weeks after doing
yeah, like you
crunches
don't,
and let's lose
yeah,
the weight.
yeah, yeah. I don't care that you got your deadlift back because I don't care that you could deadlift in the first
Yes.
place. What
Yep.
I care about is that you took care of yourself as this feminine goddess that you are. And that if that means lifting weights, great. If it means not lifting weights, great. But regardless of all of that, if you had a C-section, you need to allow your body to heal. You don't tear your hamstring and then try to go sprint the next day. Allow your freaking muscles, everything to heal. Allow your body to reconstitute itself. And I bet that if we were to have a prospective trial looking at women who ate the standard American diet and women who ate a healthy diet the way that you talk about it, and Can2 talks about it, and Milas talks about it, and Sarah and I talk about it, I bet that the risk of uterine rupture is not 0.4 to 0.9%. I bet it's 0.04 to 0.09% because your body will heal itself and that uterine scar will reconstitute itself almost imperceptibly. So much so that it doesn't become a risk factor. It's just that you had an incision, the incision closed, and while there may still be some issues with uterine contractility and probably some pelvic floor issues from yanking on the fascia and pulling it up to meet the anterior lip of that fascia, while all of that is true, we can also work through that with physical therapy. But what are we doing for women? We're saying, go home, take care of this baby, take some Norco, and we'll see you
See you in
hopefully.
6 weeks.
Yeah, right. And hopefully you don't get pregnant again for 18 months. Otherwise, we're going to schedule that C-section as soon as you get that positive pregnancy test. So there is a lot that we can do. And I think that this placentation question, there is no doubt that if you are well nourished, that you have a lesser chance of these nourishment issues and these abnormal placentation issues arising. Not to mention the big concern that we haven't really talked about, but that to me is a non-issue, is growth restriction. If you have a marginal cord insertion, they might recommend growth ultrasound. Fine. But if the baby's growing in a normal rate, it's not falling off the growth curve. That could be, if that were to happen, it could be due to the marginal cord. But are you nourishing yourself appropriately? Are you sleeping well? Are you getting all of the good foods? Are you prioritizing junk food? There's no way around it. We've been apologizing for this for so long, and our society as a whole needs to start prioritizing childbirth.
I think we're starting to see that wave. You mentioned people are starting to wake up and take control, and I see it too. It's small right now, but the momentum is gaining, and I do think it's coming. Okay,
Yeah.
I have a question about the care you're going to get in the hospital. If you do get diagnosed with one of these things, are you going to be referred to an MFM and now you have a high-risk doctor on your team from here on out? Because some people are going to find comfort in that, and some people are not.
That's a good question. I think that, so let's go back to some of the sort of original questions that we were asking. If you don't, like, a lot of women don't go to the doctor anymore, right? They just want a midwife, and the midwife is going to maybe just be measuring fundal height. There may never even be a reason to look, right? So we shouldn't be worried about this thing before it happens. But if, let's say, you are in the care of a typical OBGYN, like a generalist OB, and let's say growth is not caught up to speed, right? The first thing that we're going to do is an ultrasound. If the ultrasound shows, oh my gosh, the baby was growing, seemed to be growing well, fell off, and now the umbilical artery Dopplers are showing some abnormality, that can tell us that the placenta is dysfunctional. Maybe those are normal, but we now also have an opportunity to look at how the cord is inserting. Maybe that becomes a thing. You likely will, if the diagnosis of marginal cord is made or velamentous cord is made, especially if there's a Vasa Previa, you will very likely now have tandem visits where you go see your OB, and then 2 weeks later you see your MFM, see your OB, see your MFM. And that's really just precautionary. They want to make sure that they're missing something, that they're on top of it. But as I've said time and time again, as long as the baby's growing, the fluid looks good, and there's no other signs emerging that something bad will happen, there should not have to be additional actions. It just now may be a little bit more of a dilemma every single time you go in, because they may be recommending certain things like twice weekly NSTs or something like that, which really doesn't make any sense. It should be every week at maximum. But once you're diagnosed with these things, it's hard now
Get off
to
that.
train. Yeah. So that doesn't mean we should be afraid, because maybe one of these great doctors, the high risk or the generalist, maybe they're going to save you or your baby's life. Like, you could be one of those people that really benefits from that. So I don't want people to be afraid of hospitals or afraid of OBs, but you just have to be willing to reconcile the reality that us doctors are trained to avoid the 1 in a million, as opposed to studying and learning from the rest of those totally normal pregnancies that should not lead us to be doing interventions unnecessarily.
Okay, can we talk about induction with one of these things? Because someone might be diagnosed with it and then they're either recommended to have an induction or they choose an induction. I think it's no surprise that neither one of us are pro let's induce. If you want it,
Yeah.
let's go for it. So I would
Yeah.
like to have a conversation about how you can safely do that. But in my brain, it's we already have this variation. Think very critically and hard and long about how much you want to force your body to go into labor when it's not quite ready. And then maybe ask, why is my body not ready and showing these signs? What are your thoughts on this? And then what kind of advice would you give someone that was like, I do have this diagnosis, but I also want to be induced?
Yeah.
It's tough, I know.
Yeah. Now we're in the cultural milieu of what does your gut tell you? A lot
Yeah,
of women may, I think I want to get this labor going. And a lot of people would say, nonsense, you shouldn't be induced. Don't listen to them. But if something in your gut is telling you, I feel like we need to get things moving along. There might be some truth there. In fact, there often
totally.
is. Authoritative.
Totally.
So if that were to present itself to you where you wake up and you're like, I feel like something's off, let's check it out. Let's at least have a conversation, whether it's your midwife or OB. The question, of course, really at the heart of this question is we have this variation, right? We have something that's different here from most singleton pregnancies. If we were to induce you, and we know that the induction process is a very synthetic version of getting labor going and having a baby, are we setting you up for something, bad happening where now we're in an emergency situation? In other words, that baby already didn't have great reserve, and now we're pushing the baby before the baby's ready to come out. I think that goes for almost every conversation around induction. These babies that have growth restriction are now going to be compelled to come out of the vagina before they're ready, knowing that they already have a half of an oxygen tank,
Hmm.
right? Babies don't grow big when they don't have enough oxygen and they don't have enough nutrients coming in. There must be some reason that this baby is not growing well, apart from the rare infections like the torches and all of that. It's almost always something related to nourishment or the placental function,
Hmm.
which is leading to nourishment. So the conversation on induction really should be like, okay, what is the minimum effective dose, let's say, of whatever induction method that will gently persuade the body to get into childbirth? And there's a myriad of things that people can do that I'm sure you talk about, not least of which is things like red raspberry leaf tea. Just start drinking it. It doesn't matter where you are in your pregnancy. Third trimester, start drinking some red raspberry leaf tea every day. It's not an induction method. It's like a toning method. It's
It's like
like,
a workout for your uterus, but low key. It's like
exactly. Yeah.
Pilates
Like,
for your uterus.
right. You don't run a marathon the week before the marathon you're trying to win. You go and you do a little light jog. It's a light jog. It's just,
Like,
let's get some feels going. Obviously, anything that can release oxytocin naturally, whether it's breast stimulation. I love, like, orgasm is a great way to get
yep.
labor going. Not penetrative necessarily. Like, you may not want to do that, but as long as your waters are intact, I don't see any issue with that. Most people don't want to have penetrative intercourse at 9
Yeah.
weeks.
Yeah.
You
You're
can
like,
do,
get away from me. You're the
yeah,
reason I'm in
yeah.
this situation.
Right. You've got one foot in the astral, and
Yeah.
like you're ready to have a baby. But up until that point, that can be very tonifying. Red raspberry leaf tea. I really don't like methods like castor oil and whatnot. That is pretty aggressive because it causes an irritation of the intestines, which kind of by proxy causes an irritation of the uterus. But all of those things that I'm sure you talk to your clients about, those can get you ready. And then
Yeah.
if you have to induce, it may just be like a little whiff of cytotec that gets prostaglandins releasing naturally, and then that tells the brain, hey, I think something's happening here. Certainly exercise, getting on all fours, cleaning your kitchen floors is the method I use the most while you're drinking your red raspberry leaf tea. These are all things that can help to make the induction process minimal, right? And we have experience, of course, with trying to induce 34 weekers. It's very hard. The whole first day is just cervical ripening. And if
Hmm.
that even gets you anywhere, maybe you can get a balloon in there. And if that even gets you anywhere, then you can start talking about other things. But we have a baby here that doesn't want to be pushed for 3 days, almost certainly. And gentler, less is more, all of the things. And including, let's just really make sure that this is what we want to do, because there's a good chance that your baby's going to come naturally just like any other baby. And we maybe don't even need to be talking about induction, especially if you're the doctor who's directing this conversation, unless we have a really good reason to induce.
Totally. And then when you're in labor, we have the ways that we can check on your baby to make sure they're tolerating it well. So we can always intervene as
Yeah.
needed. Okay, so
Yeah.
can we shift just slightly to the Vasa Previa? I would like to talk about kind of the differences between that and what we've been talking about. To clarify, is this The umbilical cord, or are these actual veins that are growing on the amniotic sac, the membranes?
Right. So this is umbilical cord vessels. So if you recall, there's two arteries in one vein. The arteries are carrying deoxygenated blood from the baby to the placenta. The big old vein is carrying oxygenated blood from the placenta to the baby. I hope I said that right because that was a lot of oxygenated thrown in there. But so these vessels are growing through the membrane on their way to the placenta. There may not even necessarily be a very,
Oh,
so the cord's coming out of the baby's belly button, right? It
yeah.
then is coursing towards the placenta, but the cord never actually inserts into the placenta. The vessels come out of the cord and then course through the membranes, and then they interface with the placenta. It's a very unusual thing, very hard to imagine.
Yeah.
I've maybe seen a couple dozen of these in my life. The issue, of course, there is that we have these very important blood vessels that if you've ever seen a cord that isn't clamped, the cord
Mm,
snap, blood
it's
spraying out. That is baby.
everywhere. Yeah.
Yeah. So the baby's got this circulation that's pumping blood out and it's losing all of its blood, right? So that's why we don't want to avulse the cord without having it clamped, right? It can come out of the belly button, but you have to really yank on it. The cord itself can actually detach and you have to make sure you have a clamp on it, right? So we know that those vessels need to remain intact until the baby's physiology changes after birth as a consequence of not only the Wharton's jelly contracting, but also sometimes when we clamp it. Of course, people have seen a baby have a placenta attached and they do just fine without any clamping and cutting, lotus bursts, whatever. But the point that I'm trying to get at here is that we now have these important vessels that are coursing through a membrane that is as thin as paper. And it may be running over the cervix. So now we have a velamentous cord, which is what I just described, but those vessels are running over the cervix. So this would almost only be possible if there's consequently a low-lying placenta or a
Hmm.
complete placenta previa. If you have a complete placenta previa, a baby can't deliver through the placenta. It can, but that's not what I recommend.
Yeah.
Now, the low-lying placenta, of course, is always a pickle because if you ask Christine Laria, bringing her up again, if they're in Afghanistan in a refugee camp and there's a surgeon that has to fly in by helicopter to do a C-section and there's a little lip of placenta there, they will just nudge it out of the way
Wow.
and they get good outcomes. For us, if it's even remotely close to the cervix, we're just gonna call it quits. No vaginal birth for you. You got a C-section. Vasa previa is different because we have now the placenta previa consideration. Okay, it's not right over the cervix, so maybe we can nudge it out of the way. But the fetal blood vessels that would have been wrapped up in this big juicy cord are now flowing through a thin membrane on their way into the placenta where there may or may not be interfacing well. Maybe the baby is growth restricted as a consequence of this interface. Maybe not. We already talked about that. But now we have these vessels that have to be sliced through by a passing baby, whether it's butt first or head first.
Mm.
And that will lead to obviously catastrophic consequences. These are not maternal vessels. These are baby vessels. So that is a special conversation. Fortunately, Vasa previa is extremely rare. I think, let me get you that number there. Do you happen to know the number?
No, I don't. Your example while you're pulling that was
Sure.
super, super helpful. So I was actually picturing all of the vessels in the cord, but the cord across the cervix. And I was just thinking, why is that so high risk if we know that the cord is constantly floating and moving? But your example explained that no, in fact, it is grown into the membrane. So this
Yeah,
must
it's
also
it's
be,
immobile.
oh, it doesn't move at all. Yeah. So does that baby?
Right.
Oh, I guess it appears if you were to look at a picture that they are connected to their amniotic sac and then their amniotic sac is connected to their placenta and they actually don't have a full cord, or it looks like they don't have a full umbilical cord because it's not mobile and separate.
Yeah, they probably have a segment of cord, right? Let's say it's, I don't know, let's say it's a 20 centimeter cord normally. They may have 10 centimeters of cord, and the rest of the cord, instead of it going straight to the center of the placenta, it like merges into the membranes, and
Yeah.
those vessels are now coursing along the membranes into the placenta. And in the
Huh.
case of vasa previa, that special circumstance is happening in a way that those vessels may be transected by a baby passing through the cervix out into the pelvis. The baby would effectively be scuba diving and then cutting its lines while it's underwater.
Yeah.
Not a good,
What about
not a
when
good.
the water breaks? Is that a concern too? Because if the amniotic
Yeah.
fluid breaks and then the cords break with that, it's, oh my gosh, now we
Yeah.
have a problem.
Yeah, the Vasa Previa cases are usually going to be recommended before labor even happens. And so if in the rare circumstance that you had like PPROM with Vasa Previa, that would be a good reason to rush to the hospital.
A true
Not a
emergency.
guarantee that those vessels are going to be transected, but because they're interfacing in a funny way when the membranes rupture, you just have to consider the baby's still attached. Like the vessels are still intact, but now we have a strange dynamic where those very friable, those very delicate vessels are just
Mm-hmm.
exposed now to baby's parts and stuff pushing against it, especially if you're contracting. So since we don't have a lot of just observational data, okay, what happens if the water's open and you just have your baby? I don't know if we're ever going to know because the risk there is pretty substantial.
Yeah. Yeah. Okay. What are those numbers of Vasoprevia?
It's pretty darn low. It says 1 in 1,218 pregnancies in this one list study that just popped up from the British Medical Journal. That sounds a little high to me. I'd say we're probably looking at probably half of that. And then, of course, you'd have to get into the methodologies and see what were they actually characterizing as Vasa previa.
Sure.
Just look kind of close, or is this definitely right over the cervix? Who was diagnosing it? How were they diagnosing it? Using what type of ultrasound? The thing about ultrasound, and this is good for everything from growth restriction to accreta spectrum disorders, if you see it, you're almost certainly right. But if you
Hmm.
don't see it, I said this before, if you don't see it, it doesn't mean it's not there. So how many of these cases in this study did we really see Vasa previa? Because maybe we missed some and maybe the number's actually higher. But the point being here is that you have probably a better chance of winning, not the lottery, but going into a casino and making a whole bunch of money on the roulette table than you do having a Vasa previa in any specific singleton pregnancy.
Yeah. That's comforting. That's really comforting to know. It sounds like you don't have too much choice in that. The best way is a C-section, but we'll wrap up here. I guess my last question for you is, how would you advise somebody to talk to their doctor about having a low intervention birth if they do have a diagnosis of, let's say, MCI or VCI, and keeping in mind that VCI is a little bit higher risk than MCI?
So we're talking from the standpoint of the client now.
Yeah,
How to have
just
a
like how would
conversation.
you approach a doctor who is saying something like, you know what, we just have to have a C-section, not for Vasoprevia, but for the other two things, or to say, I absolutely cannot let you go past your due date. You must be induced. It's just the safest option.
Gosh, there's so much wrong with that, with what the doctor's saying. I like to counsel people to ask questions in response to the doctor's questions. So what that might look like is, oh, okay, why do you recommend induction? We think your child's going to have a hard time and we think the placenta is not doing well. Okay, if we induce or augment, don't you think it might push the baby a little harder than they want to go? Wouldn't that be a reason to await natural birth? You know, the placenta might poop out on us before we get there. So we want to get things going. Okay, do you think it would be, reasonable, given you're concerned about the placenta, do you think it'd be reasonable to maybe try some natural methods first? Or how would you propose that we do it so that it's not going to stress out my baby anymore? And that might actually create a beautiful dialogue. Maybe the doctor would say, what methods are you concerned about or whatever? I don't really want to go with the high dose Pitocin. Yeah, I don't think that's a good idea either. It might turn into a nice compromising and a negotiating as to how we do this as opposed to protocolizing it. Of course, you can always ask for additional testing. The problem with the additional testing is that it's very subjective. So in
Mm.
order to do a full BPP, people don't realize this, but a BPP takes a full 30 minutes or more. So in a 30-minute period, they have to sit there with the ultrasound for 30 minutes and they have to look for the the four movements, including the water. So we'll say three movements. The fifth element, of course, is the NST, and a lot of people miss that. But the BPP is really not indicated unless there's an abnormality on the NST, which is just a 20-minute tracing, right? AC cell is moderate variability. You don't see any D cells, you're done. There's no need to do a BPP. That's my preference. Everybody has different opinions about this. The MFMs they probably have a slightly lower
Sure.
threshold to do more stuff because they're so gifted with the ultrasounds and whatnot. But you can always ask, regardless. You can ask, hey, could we do a BPP if we're worried about the growth? Like the baby's been growing well this whole time. I'm not so sure why we're so concerned now. Something that people like Stu and Milo have taught me is a small baby is really not a big deal unless the baby was normally growing well and suddenly has stopped growing or has decreased its growth rate. That's when we get concerned about the placenta. If your baby is constitutionally small because you and your partner are 5'4", it might just be a small baby. It doesn't matter if it's an MCI or not. The other thing that people need to be aware of is that your fundal height, 32 weeks is 32 centimeters, 34 weeks is 34 centimeters, 36 weeks is 36 centimeters. 37 weeks, it's 34 centimeters. Oh my God, the baby shrunk. No, the baby didn't shrink. The baby is now getting into the pelvis. So
Yep.
your uterine height, the fundal height shrinks. Don't let that be a reason that they go and start investigating and looking for things that probably don't matter anyways. If you have had a totally normal, healthy pregnancy and you've been taking care of yourself. My wife called me in our first pregnancy. I was still working in the hospital and she was like, honey, I'm at the OB's clinic and I'm seeing a new doctor today. I think she was seeing one of the midwives and they have CNMs in their practice. And she was like, they're worried about how big the baby's growing. So they're going to send me down for an ultrasound. I was like, what do you mean? It was at the 37-week visit. And she was like, they said that the height of the fundus, she doesn't use the same language I do. She was like, the measurement was like 3 centimeters behind where they'd like it. And I was like, but last week it was right on. So did the baby shrink all of a sudden? No. And so of course I was like, okay, let's get the ultrasound. Unfortunately, they didn't find anything there that they wanted to raise the alarms about, but that is a common issue, the shrinking baby issue at 37 weeks, when the baby starts to get into your pelvis, like it starts descending. And of course, the fundal height shrinks. That's supposed to happen. So there's a myriad of reasons that people may compel you to do other things. But if there's really no true growth issue, there's no fluid issue, yours look fine. Like you've got a baby there that doesn't need to be evacuated prematurely. And the only way to really, I think, navigate that is to have a conversation and ask as many questions as you feel like until you feel like you're really content with your answer.
Yeah. Yeah. Nice. I feel so like whole and complete after this. Thank you very much. I feel like I learned so much. And I also feel like you took a topic that is traditionally really scary. And not to say that it's not a big deal. I totally understand that getting diagnosed with one of these things is probably very scary, but you made it manageable. You made it digestible. You made it like, okay, we're going to be all right. Here are the numbers. And I really appreciate that. I've had you on the show before just because I think your presentation of things is really awesome. And I love how much you respect autonomy. It truly is. It's like the people that are in my inner circle and my people are people who really respect autonomy. So thanks for being here. Thanks for sharing this with us. If people wanted to continue to learn with you, learn from you, or connect with you, where can they do that?
Find me on Instagram. I think that's probably the best way. Nathan Riley, OBGYN. You can find my Born Free Method program there. You can consult with me at my website, which is Beloved Holistics, but everything is listed on that website. I do want to tell people that I get so many requests to consult now that I've developed a new model. And it's really to try to, in hopes that people will start thinking about the other people in their community. So I don't charge for consults anymore.
Wow.
Instead, after we consult, I ask you to make a donation for the next person in line. And whatever you're willing to give and you're able to afford will then roll into the care for the next person. Since I've done this, women have to now start considering how am I supporting the next person in line? It's a means of paying it forward. So consultations are at zero charge. I just invite people to make donations for the next person in line. And those donations wildly vary in value, but the next person in line is oftentimes very grateful because the person before them was so generous. So I want to invite people to consider these different models because I think this is more than a transactional thing that we do in birth work. This has to be a relationship, and it's not just between you and your doctor, it's between you and the other people in this community at large. There's enough to go around for everybody. We have to be starting to care for one another as birth workers,
Hmm.
also as a community. And so I'm trying this model out. If people want to find me, they can find me.
I love that. Oh my gosh, you're such a genuine soul. Also, before I let you go, if there's any doulas or birth workers, or we would love to have other OBGYNs, midwives, nurses, L&D nurses, you have a conference
Yeah.
coming up in the fall. Tell us all about it. This will be my second year going, you guys. I'm
Yeah.
a big fan of it and I'll be there. So if you're interested in hanging out with me, come on down.
Yeah. Yeah. HeHe and Caitlin are going to be back in
Yeah.
Louisville. Well, we're doing it at the big, beautiful Omni Hotel in downtown Louisville. We're not doing one in 2025. I have some other things I need to work on for the next year, but this is a development on what we did last year, which is really an opportunity for any type of birth worker, advocate, whatever to come out and really appreciate the nuances of twins births and naturally as a condition of that breech births. Interestingly, we had a couple residents, OB residents last year. There was a family medicine resident and an OB resident who came. This year we have I think close to 10 OBs coming.
Wow.
Not
Yay.
including our speakers. Yeah, so we have some OBs. They're all international, except for a couple coming from Washington State. They're coming to do the work, and we're not even offering CMEs to doctors because that was so expensive. And we don't have a lot of doctors that come, and if they could get off work anyways, because OBs are the busiest in the hospital. They really are busy people. But we have about 10 people coming. The rest are midwives, doulas, and childbirth educators. And you can expect to hear from people like Stu Fishbein, Christine Lauria, David Hayes, Rick Safries, both are coming from Reach Without Borders, Betty Ann Davis, Carol Gauchi. We've got Tracy Vogel, who's an OB anesthesiologist up in Pittsburgh, an amazing woman. Hermine Hayes Klein is coming to speak.
Oh, yeah.
Gosh, who am I forgetting? And then, of course, our two keynote speakers are Sheila Motse. Dr. Motse, from an indigenous midwife from South Africa, is doing a virtual presentation because she couldn't get herself on a plane. It was just logistically too hard for her. But Doña Lina Martinez Miranda is coming from Mexico. She's probably attended 15,000 births. She's going to talk about rebozo techniques and some other cool things. She'll be there in person. And then we have a variety of other really fun things, including the ample opportunity to do simulator practice with one of our instructors. Denny Hartung's going to be there as an attendee, but he's going to be running one of our simulators. Elizabeth Beachy is another midwife from Pennsylvania who's doing a lot of great work coming down to help with the simulator instruction. Just a really captivating, very midwife-led cohort of speakers this year. The dates are August 8th through the 11th, and throughout the weekend, you being there in person are going to enjoy some ecstatic dance, some breath work, a musical ceremony from Rebecca Kelly G. We're going to do some film screenings and have some live panel discussions around Black maternal mortality. We're going to have some art, and we're going to have a living altar. This is going to be very ritualistic, very ceremonial in all the lovely ways, so that all of the attendees can leave feeling very nourished, as opposed to just having been spoken to for 3 days. It's going to be a really special time. So that's, if you want more information, I don't know when this is going out, HeHe, but we probably have about 15 spots left because we have people coming and going. Born Free Twins Breech is the website for that. So if you're listening and you want to come and meet everybody, including me and HeHe, come on out. We'll see you in Louisville.
Come on down. You guys, before I let you go, I just want to let you know that as a doula, you're probably thinking like, why would I need to know this? I'm not delivering babies. I certainly am not. But what I have found to be super beneficial is two things. First, when someone gets word that their baby is breech, or people who have just gotten word that they are having twins, they are scared and they are looking for someone to explain to them what is happening in their body. And our teams can successfully do this after going to this conference. The second thing is, a lot of providers only know about extraction. So just because someone says, oh, I'm trained in breech, it means they're reaching up in that person's vagina, taking that baby by the feet and pulling them through their vagina. There are other ways you can do this. And so one of the things that I have learned from this conference and love doing over the last year, explaining to people that yes, your doctor may present themselves as breech trained, but you should ask more questions about what that's going to look like for you and your experience. And if that doesn't sit well with you, I've got practitioners who can do things differently that you can talk to. So as a doula, I know you're probably like, why would I go to this? I'm not going to be delivering babies. It has so much information that you will be able to pass on to your clients to help them feel in control of the decisions in a pregnancy that maybe they don't know anybody else that has had a breech baby or a twin birth, and you're the only person that has the information willing to share that. So just think about that. We'll link everything in the show notes for you. Nathan will send those links for me or to me for all the data that we talked about as well. I will see you guys in the next episode. Until then, connect with Nathan on Instagram, and you can find me at Tranquility by HeHe or at the .birth.lounge. Until next time, download the Birth Lounge app for more evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye.
Bye.
Thank thank you so much for tuning in today. I truly do value this community and I love hanging out with you. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent. It's an honor to be your go-to gal when it comes to preparing for your baby. If you found today's episode helpful, share it with a friend. Share it with someone who could use evidence-based information to help them have an informed and confident birth. I'd love to hear what you have to say and read your sweet words. By leaving us a review, you are helping other expectant mamas and their families find the podcast so that we can reduce birth trauma and improve maternity care in the U.S. one birth at a time. If you're interested in joining the Birth Lounge, go to thebirthlounge.com. If you want to connect with me on socials, you can find me at Tranquility by HeHe on all platforms. Until next time, stay educated, stay supported, stay confident. Bye!